Esophageal varices. Bleeding or hemorrhage from esophageal varices occurs in approximately one third of patients with cirrhosis and varices. The mortality rate resulting from the first bleeding episode is 45 to 50%. It is one of the major causes of death in patients with cirrhosis. The mortality rate increases with each subsequent bleeding episode. Pathophysiology. Esophageal varices are dilated tortuous veins usually found in the submucosa of the lower esophagus, but they may develop higher in the esophagus or extend into the stomach. This condition nearly always is caused by portal hypertension, which in turn is due to obstruction of the portal venous circulation within the damaged liver. Because of increased obstruction of the portal vein, venous blood from the intestinal tract and spleen seeks an outlet through collateral circulation. That is, new pathways of return to the right atrium. This effect is increased pressure, particularly in the vessels in the submucosal layer of the lower esophagus and upper part of the stomach. These collateral vessels are not very elastic, but rather are tortuous and fragile and bleed easily. Less common causes of varices are abnormalities of the circulation in the splenic vein or superior vena cava and hepatic venothrombosis. Bleeding esophageal varices are life-threatening and can result in hemorrhagic shock, producing decreased cerebral, hepatic and renal perfusion. In turn, there is an increased nitrogen load from bleeding into the GI tract and an increased serum ammonia level, increasing the risk for encephalopathy. Usually, the dilated veins cause no symptoms unless the portal pressure increases sharply and the mucosa or supporting structures become thin. Then massive hemorrhage takes place. Factors that contribute to hemorrhage are muscular exertion from lifting heavy objects, straining at stool, sneezing, coughing, or vomiting. Esophagitis, irritation of vessels by poorly chewed foods or irritating fluids, or reflux of stomach contents, especially alcohol. Salicylates and any medication that erodes the esophageal mucosa or interferes with cell replication also may contribute to bleeding. Clinical manifestations. The patient with bleeding esophageal varices may present with hematemesis, melena, or general deterioration in mental or physical status and often has a history of alcohol abuse. Signs and symptoms of shock. Cool, clammy skin, hypotension, tachycardia may be present. Assessment and diagnostic findings. Endoscopy is used to identify the bleeding site along with barium swallow, ultrasonography, CT scan and angiography. Endoscopy. Immediate endoscopy is indicated to identify the cause and the site of bleeding. At least 30% of patients suspected of bleeding from esophageal varices bleed from other sources, that is gastritis and ulcers. Nursing support can be effective in relieving anxiety during this often stressful experience. Careful monitoring can detect the early signs of cardiac dysarrhythmias, perforation and hemorrhage. After the examination, fluids are not given until the gag reflex returns. Lozenges and gargles may be used to relieve throat discomfort if the patient's physical condition and mental status permit. If the patient is actively bleeding, oral intake will not be permitted and the patient will be prepared for further diagnostic and therapeutic procedures. Portal hypertension measurements. Portal venous pressure can be measured directly or indirectly. Indirect measurement of the hepatic vein pressure gradient is the most common procedure. It requires insertion of fluid-filled balloon catheter into the antecubital or femoral vein. The catheter is advanced under fluoroscopy to a hepatic vein. A wedged pressure, that is similar to pulmonary artery wedge pressure, is obtained by occluding the blood flow in the blood vessel. Pressure in the unoccluded vessel is also measured. Direct measurement of portal vein pressure can be obtained by several methods. During laparotomy, a needle may be introduced into the spleen. A manometer reading of more than 20 ml saline is abnormal. Another direct measurement requires insertion of a catheter into the portal vein or one of its branches. Endoscopic measurement of pressure within varices is used only in conjunction with endoscopic sclerotherapy. Laboratory test: liver function test, serum aminotransferase, bilirubin, alkaline phosphatase, and serum proteins splenoportography, which involves serial and segmental X-rays, and hepatoportography and celiac angiography. Medical management: the extent of bleeding is evaluated and the vital signs are monitored continuously when hematemesis and melena are present. Signs of potential hypovolemia are noted, such as cold, clammy skin, tachycardia, a drop in blood pressure, decreased urine output, restlessness, and weak peripheral pulses. Blood volume is monitored by a central venous pressure or arterial catheter. Oxygen is administered to prevent hypoxia and to maintain adequate blood oxygenation. Electrolyte imbalance: intravenous fluids and electrolytes and volume expanders are provided to restore fluid volume and replace electrolytes. Transfusion of blood components also may be required. An indwelling urinary catheter is usually inserted to permit frequent monitoring of urinary output. Pharmacologic therapy: vasopressin, that is pitressin, may be the initial mode of therapy because it produces constriction of the splanchnic arterial blood and a resulting decrease in the portal pressure. Second one, monitoring of fluid intake and output and electrolyte levels is necessary because hyponatremia may occur and the vasopressin may have the antidiuretic effect. The combination of vasopressin and nitroglycerin, that is administered by the intravenous, sublingual and transdermal route, has been effective in reducing or preventing side effects, constriction of the coronary vessels and angina caused by vasopressin alone. Somatostatin, that is sandostatin, have been reported to be effective than vasopressin in decreasing bleeding from the esophageal varices without the vasoconstrictive effects of vasopressin. Propranolol and nadolol, beta blocking agents that decrease portal pressure, have been shown to prevent bleeding from esophageal varices in some patients. However, it is recommended that they may be used only in combination with other treatment modalities such as sclerotherapy, variceal banding, or balloon tamponade. To control hemorrhage, balloon tamponade may be used. This procedure, pressure is exerted on the cardiac, that is upper orifice of the stomach, and against the bleeding varices by a double balloon tamponade, that is sense-taken Blackmore tube. Already we have read in the shorts, so just go through the shorts for the detailed notes. And another one is endoscopic sclerotherapy, esophageal banding therapy, that is variceal band ligation, variceal banding. Then another one is transjugular intrahepatic portosystemic shunting, that is TIPS, transjugular intrahepatic portosystemic shunting. Then another one is surgical management. In surgical management, procedures that may be used for esophageal varices or direct surgical ligation of varices, splenorenal, mesocaval and portcaval venous shunts to relieve portal pressure, and esophageal transection and devascularization. And surgical bypass procedures that are distal splenorenal shunt, a mesocaval shunt, portocaval shunt, and partial portocaval shunts with interposition grafts. mesoatrial shunt, and mesoatrial shunt is that is in Budd-Chiari syndrome. This mesoatrial shunt is used there. And devascularization and transection. These are all the surgical procedures. Nursing management. Overall nursing assessment includes monitoring the patient physical condition and evaluating emotional responses and cognitive status. Nurse monitors the records vital signs, assess the patient's nutritional and neurologic status. This assessment will assist in identifying hepatic encephalopathy resulting from breakdown of the blood in the GI tract and rising serum ammonia level. Manifestations range from drowsiness to encephalopathy and coma. Complete rest of the esophagus may be indicated with bleeding, so parenteral nutrition is indicated. Gastric suction is usually initiated to keep the stomach as empty as possible and to prevent straining and vomiting. The patient often complains of severe thirst, which may be relieved by frequent oral hygiene and moist sponges to the lips. The nurse closely monitors the blood pressure. Vitamin K therapy and multiple blood transfusion often are indicated because of blood loss. A quiet environment and calm reassurance may help to relieve the patient's anxiety and reduce agitation. Bleeding anywhere in the body is anxiety provoking, resulting in a crisis for the patient and family. If the patient has a heavy user of alcohol, delirium secondary to alcohol withdrawal can complicate the situation. The nurse provides support and explanations regarding medical and nursing interventions. Monitoring the patient closely will help in detecting and managing complications. Thank you.